What's up, Des Moines? Doc Ladd here with the Fit Moines podcast, the podcast where we sit down with the people helping Iowans feel better, move better, and perform better. Today, I'm joined by Dr. Brian Handel, an orthopedic spine surgeon at DMOS, specializing in minimally invasive spine surgery, artificial disc replacement, robotics, and some of the newest technologies shaping spine care. In this episode, we'll break down back pain, sciatica, herniated discs, MRIs, when surgery is actually necessary, and how AI and emerging technology are changing spine surgery. If you've ever wondered whether your back pain is something to worry about, whether surgery can be avoided, or what a spine surgeon wishes you knew before walking into their office, this episode is for you. Dr. Handel, welcome.
Hey, thanks for having me.
Absolutely. All right, so before we get started, I've got to know, this is kind of my burning question here is, most of the orthopods I know don't want anything to do with the spine.
Yeah.
So I'm curious, what was it about the spine that drew you to surgery there?
Yeah. So whenever I was a medical student, whenever I was in my family medicine type rotation, which they typically make you do, I was introduced to orthopedics through a spine surgeon. So I thought spine surgery was orthopedics, man. I had no idea.
Yeah.
So I did some of my first rotations in orthopedics and spine surgery, and I just loved it. And then when I got into orthopedic residency, the whole thought process, I was going to do spine surgery. But then I got introduced to hand and joints, and I really loved joints a lot. But then when you start doing these rotations, you kind of get a feel for like the things you want to do for the rest of your life.
Right.
And for me, it was, I would see a person come in my office, and when it came to knee pain, there was only a couple things you could do. You could scope it, you could replace it, you can inject it, and then that was it.
Yeah.
With spine, it became more of, I had to really, if you wanted to do a great job, you had to really dive into what that patient's goals were.
Sure.
What did they want to get back to doing? What are their comorbidities? And what their overall lifestyle is like, family support, job, things like that, because it doesn't cut all the same. And so I was able to see how I could do a minimally invasive surgery, maybe for something temporarily, or something even more is, if someone had a severe scoliosis, I'm doing a large surgery. So there's a big spectrum to surgery and spine. And it was a la carte menu that you could do for a patient to change their life, which really attracted me to spine surgery.
Sure. Okay. So to break it down to a little bit more for the listeners, spine or orthopods aren't the only ones that do spine surgery.
Yeah.
So like when I was in Okinawa, the neurosurgeon was the one that did, like I said, orthopods there wanted nothing to do with it, but our neurosurgeon was the one that would do any of the back surgeries. So can you give us a breakdown of like what's the mix of surgeons that are doing that?
Yeah. So I mean, orthopedics, I would say it's probably most neurosurgeons are going to be focusing on cranial.
Sure.
So brain, things like that. Now there are some neurosurgeons that simply just focus on spine. And so like the Iowa clinic here, they have great spine surgeons that are neurosurgeons. All of them are neurosurgeons. And some of them are specifically vascular, and they do mostly brain and clippings and aneurysms.
Sure.
But a lot of them focus on spine. Like my training, my fellowship was 50% neurosurgery and 50% orthopedics. And so a lot of my training, even though I'm an orthopod, was actually by neurosurgeons. And so you get it. I think if you have a patient that's going to go seek out a spine surgeon for whatever consultation, I think that's important to figure out whether it's an orthopod or a neurosurgeon, is what was your exposure to spine surgery? Because you're a neurosurgeon, I know some neurosurgery residencies that actually had very little spine surgery exposure, and a lot of it was cranial. So it just really depends on where you're at. But we do this, the wide breadth. I would say that probably the only things I don't do are going to be like spinal cord tumors, and then like at the occipital cervical junction. So in that region for spine surgery.
Okay. So that's a referral out.
Yeah, exactly.
Okay. What would you say is the hardest operation you've performed?
So the hardest operation, I think, is, that's a loaded question. I think a lot of it has to do with just revision spine surgery. It's a love-hate relationship for me. When I got into town here 2 years ago, I had to kind of break into the market because there was spine surgeons here. And so coming from Florida, the spine capital of the world, a lot of what we did was revision spine surgery. And so I felt like that was a kind of a missing facet here in Des Moines. So
Okay.
a lot of my practice when I first started was actually just revisions. And so those are the most difficult, whether they're small or large, because you're taking, there's a psychological component to it. Patient already has an outcome that they're not happy with.
Right.
And we got to break that down of what happened there and then bring them hopefully to a favorable outcome depending on what's kind of going on. So it's
Sure.
not actually the surgery itself, it's actually the relationship and the psychological barriers to get patient back to their life. I think those are the most difficult, because those are the ones like you got mom and dad in the room, you got brothers and sisters, the whole family's there,
Yeah.
and you're trying to really, really connect with the patient to build that trust bridge back. That's
Right.
very, very difficult
Right.
sometimes.
Yeah. Yeah. I would say the same from a physical therapy standpoint for your chronic low back pain patients. It's difficult.
Right.
It's like you said, there's a lot of the psychological component more than the physical component, or a good mix of both, you know?
Right. Exactly. Like an ACL, right? Like
Yeah.
you get an ACL in a young athlete who,
Oh, yeah.
you know, has this textbook surgery, and then you're getting them cleared to play. And a lot of it's going to be psychological to get them back
Oh, yeah.
on whether it's the pitch or the court. It's
Yeah.
a lot of it is like, you can trust your knee. Don't worry.
Right.
It's good to go. We did
Yeah.
this in the gym, and a lot of them, it's very difficult.
Yeah. Yeah. I didn't know that you mentioned that. I just had an ACL patient the other day that we were working on just going up and down a step, and she's like, I can't do it. And 5 minutes later, she's going up and down the steps over here 10 different times. And I was like,
Right.
you could do it the whole time. It
Right.
was just,
Yeah.
it was all in here.
Right.
And so, yeah, and back pain, it's debilitating at times. And so when you live with that for so long, and then, you know, then it's like, well, do I have surgery or not? And like you said, if we're going for a revision, like there's a lot of layers to all that you've got to uncover. And so, yeah, that could be very hard. So you've got a background in molecular genetics and software development. So how is that a little bit different from surgery? How has that influenced your surgical approach?
Yeah. So let's rewind. I'm a little bit older than some people that come in. I'm 38 years old. So I had another life where I was working in Houston, Texas at MD Anderson, and
Okay.
we were working on the next generation sequencing. So like whole genome sequencing. And
Yeah.
so there was these new platforms where we take your DNA and we do cancer research and things like that. So essentially what I was doing is I was building a platform where I would take a patient's blood, put it in a system, it would analyze their entire DNA, and then I was able to find what your risk for us developing certain cancers.
Oh, wow.
And so how that kind of, if you see the parallels in spine, you have to kind of condense a lot of data in a very short amount of time.
Sure.
And then find treatment protocols for that. Very similar to spine. I have, 30, 45 minutes to sit down with a patient. They want to tell me their entire life story,
Yeah.
but I have to condense that, and I have to speak it back to them in their language, and then kind of figure out a treatment protocol for them. So there are some parallels there, but whenever I was my mentors at that time at MD Anderson, that we were doing all the software development, and they were like, "What are you doing? Like, you just go become a doctor." And I was like, "Well, maybe I'll become a geneticist, and maybe I'll be a pathologist." And they were like, "No, you don't want to do this. You go find what you love. Go to medical school. You'll do great." And so I took their advice, and here I am.
Yeah. So now I was also reading you were a professional violinist.
Yep.
Was that at the same time, or
No. So
different life as well?
Different life as well. So keep going back, all the way to high school. I started playing the violin when I was 7 years old, and my parents, they never graduated high school or anything. And so for them, they wanted me to achieve the highest level of education. So
Sure.
they're immigrants. And so they thought, well, how do we do that? Well, let's get him on the violin, classical music, that'll help him develop his hand-eye coordination and things like that. So it was just something I loved, and I continued, and I played at Carnegie Hall. I won the BET Jazz Award. There was all these kind of great accolades that I was able to achieve. And I was playing with the Houston Symphony whenever I was living there. And then at the time I was going to go on to become a concert violinist, but they were on a strike. The state of Texas actually reduced some funding for the Houston Symphony. And so it was a decision: do I, go to college, or do I go work with my dad at his car shop?
Yeah.
Or, do I continue with this, the violin? And so I went off to college and tried to just figure it out. And
Yeah.
I did.
Find your path, huh? So we talked about it a little bit already, but why does everyone's back hurt?
Yeah. Yeah.
I know that's a broad question.
Broad question, right?
Let's get into that. Yeah.
So many things. And when a patient comes in and they just want to talk about their back pain, the last thing I want to do is try to normalize it for them. I want to hear them out, because when I first started, I thought it was very appropriate for me to say, well, I have back pain too. What's so different about, and that already creates a confrontation.
Right.
Like, what's so different about your back pain? And so obviously this patient has come in here to trust me to tell me their story. And so a lot of times what I want to know more about when it comes to their back pain is, when is it happening? It's not very helpful. So for the patients listening, it's not very helpful if you tell me it hurts all the time. It can't hurt all the time.
Mhm.
There's certain motions that you're particularly doing.
Sure.
And I've done a lot of, research, because there is no clear cut of why back pain is so prevalent, because there's so many reasons. One of them can be genetics. One of them can be weight. One can be diet and inflammation.
Yeah.
But I do think that there is this whole spectrum that has to do with the pelvis. I truly think that a lot of back pain is driven by hamstrings and pelvic morphologies. And I think that drives a lot of back pain. Because if you think about the whole axial skeleton, I'm looking at one of your skeletons over here in the side of the closet. It's literally, the whole skeleton is one big pendulum.
Right.
And it's big tension bands. And so if your hamstrings are tight, that pulls on your pelvis, which pulls on your low back, and your multifidus and everything is tight. And if your core is not weak, then you hunch over. There's just so many things in play, and it's very complex. And so it's not just about the bones and the disc and the nerves. There's a whole other pathophysiology around it than just the spine itself.
Sure. Now, a lot of the other surgeons I've talked to have said, a large percentage of their patients don't end up getting surgery. Is that the same in your situation?
Yeah, exactly. And that's why again, when you have back pain, when you go to see a spine surgeon, which definitely should not be your first stop, because
Right.
I always tell patients, I'm a hammer, you're a nail. You come into my office, I'm a surgeon. Where the thought process is, we're going to be talking about surgery.
Right.
But the reality is that there's, most of the patients that are getting surgery have exhausted so many things prior to getting to my office, whether it was physical therapy, injections, other previous, maybe minimally invasive pain management type procedures. So as far as why patients don't go to surgery, is because a lot of it is treated non-operatively without any surgery. Like myself, I have a spondylolisthesis, or a slip in my back. And I'm just talking to my partner today because he has back pain.
Yeah.
And so we're going through different types of exercise I do, certain medication regimens that I do, as well as TENS units and stretching that help me get over my back pain so that I can do what I love, which is spine surgery.
Yep. Absolutely. Let's talk about MRIs a little bit, because that seems to be a pretty scary topic.
Yeah.
And it seems like, there's a lot of research out there that shows that, just because there's a herniated disc or spondylolisthesis or something on that MRI, that, it's a big scary thing, and people kind of freak out when they read those things.
Yeah.
But it doesn't necessarily mean there's pain,
Right.
or that they'll need surgery.
Right.
But that's a very confusing thing for patients, I think. So
yeah.
Can you talk about that a little bit?
Yeah. I did a social media post on this not too long ago that said that your MRI is lying to you.
Yeah.
Yeah. It's because, when a radiologist reads the MRI, they're just being comprehensive. They're talking, and there's so many things are fine incidentally, whether it's a neurofibroma, like a small benign spinal cord tumor.
Yeah.
And then patients think, oh, that may be why I'm having back pain.
Sure.
Or maybe it's just some fluid in the facet or something. And so what's more important about the MRI is talking to a clinician, whether it's a pain doctor, a family doctor, or a spine surgeon, or an NP or PA, about what you're experiencing, and then matching the symptoms to the MRI versus the other way around, which is like, let me look at the MRI, let me try to find it on you, kind of thing.
Yeah.
Because the likelihood is, I see so many patients with completely normal MRIs, and they have debilitating back pain. And then I get these patients with severe degenerative disc disease, arthritis, and scoliosis, and I think they're about to talk to me about back pain. And all they want to talk about is that they just have a little bit of nerve pain, and they have zero back pain. And I'm like, how does that make any sense? And so the reality is what's more important is just talking about the clinical, because I really, it sounds crazy. I don't really care what the MRI looks like. What I care about is the patient in front of me, and then trying to match their overall functionality to that MRI.
Yep. Yeah, it's so interesting. I remember a time in Okinawa talking about spondylolisthesis. Had this patient and had some back pain, got an X-ray, which isn't the first step either, but
Right.
we did, and it's like hanging on the cliff here.
Yeah.
And I kind of freaked out because I was like, oh, I've never seen one that bad.
Yeah.
And so that was one I was like, I'm gonna
Yeah.
call up to the neurosurgeon. He was
Yeah.
a floor above us, and so I called up, and he saw the patient pretty quickly,
Mhm.
and he even said too, he's like, that was pretty intense, but he did his exam. He's like, she has like no issues, no neurological issues. He's like, I'm not going to touch her until
Yeah.
she starts. He's like, I don't know how she doesn't.
Yeah.
But
Yeah. No, it's funny that you say that, because we literally on Monday, we had a patient that came in who had what you're talking about. It's called a spondylolisthesis, which is essentially a complete almost dislocation of L5S1.
Yeah.
And it's generally a genetic malformation of the spine where the spine slips so far, and there's different grades to it. But she comes in, all we have is an X-ray, right? This is why it's so important. So I look at that X-ray, and she's standing on the X-ray, and she's standing upright. Lordosis looks fine. She just has the spondylolisthesis. And I tell my PA, and she'll tell you, I say, I bet you she has no back pain. And she goes, no, she has to have back pain. I was like, she may have nerve pain, but just go in there, maybe test out her hips. And then she goes in there, and she was like, can you come take a look? She says she had severe thigh pain that radiates into her butt. And I was like, okay. So I go in there. I'm like, let's get a hip X-ray. Complete femoral head. She had been taking so many steroids for back pain and leg pain that the femoral head had completely developed what's called avascular necrosis and collapsed. And so now her hip was essentially subluxed. And so now she needed a hip replacement, not a back surgery. But everybody was so focused on this back thing because they saw it on the X-ray that they completely forgot about looking at the whole patient.
Yeah. That's a crazy story. That's a different surgeon too.
Yeah, exactly. Yeah. So we got them over to one of our hip docs, and they're going to be doing great soon.
Yeah. So let's talk about, maybe some findings on MRI that are concerning. When should, if someone's seen a physical therapist, or maybe they've just seen their family practice doctor, they get an MRI, I guess let's back up a little bit. When should they get an MRI? Yeah. And then when you see something on that MRI that they would need surgery for, like what's the next step there?
Yeah. So first of all, again, this kind of goes, just because I've been doing so much of it. When to get an MRI really depends on the incident and when it occurred. So if we're talking to somebody in the workforce, right? Yeah. And you have an injury during work, I would say it's probably prudent for you to get an MRI right away, just because it's more documentation reasons. If you had a work injury, you need to get an MRI so that we can document. Let's get that off the table. Let's say you're just a normal human being. When you have back pain, leg pain, when do you get an MRI? Once you've trialed anti-inflammatories like ibuprofen, naproxen, Tylenol, you've seen your family doctor, you've done some physical therapy, because to be honest, like I have a slip in my back. I've tried these things, and every time I think I'm right at the edge about getting an MRI, it all goes away. Yeah. And so if that's happening, it's probably not worth getting an MRI because of what we talked about. You're going to find something. You're going to find something incidentally. And then the questions in the back of your mind is it something that needs surgery? Yep. And so a lot of times it doesn't. And so a lot of times I'm saying, just exhaust those things. If we got to get them right, then yeah, then we can sit down. But typically once you've exhausted those first things, then that's a good time to get an MRI so that we can start going down a different path as far as escalating the non-operative things regarding back and leg pain.
Yep. Let's define some terms here. So there's a lot of different terms that we hear, when it comes to the back. So bulging disc, herniated disc, degenerative disc disease, stenosis. We've already talked a little bit about spondylolisthesis, but there's a lot of terms, and a lot of them are scary. So
I got a model here. I got a model here. All right. So when it comes to disc bulges, right? Essentially, this is kind of like a pimple. This is the pimple that hasn't expressed itself yet. It's just a kind of a little protrusion. And so when we look at the spine itself, like this is looking at your spine, front, the back, we have the spine bones, we have the yellow is the nerves. This is the disc, which is the cushion in between. So when this disc kind of protrudes backwards, that's called a protrusion, or kind of ballooning backwards into the spinal cord. When you hear disc sequestration or extrusion, that means it's popped. It's popped and it's now in like pressing against the spinal cord and has probably gone up or down on the spinal cord. So those are the disc herniation. Degenerative disc disease is essentially what we see here. So this is a normal disc. And then this is a degenerative disc where the disc has completely gone away and collapsed. Now it's bone on bone. And so now you can see things like the foramen, or where the nerve comes out here, the hole is now collapsed as well. And that can cause leg pain. This can cause back pain. So this is degenerative disc disease. And we already talked about one of them, spondylolisthesis. What typically happens when you develop degenerative disc disease is this disc is supposed to take up about 60-70% of your load in your back. But when it collapses, now the joints, the facets back here start to take the load. They start to overgrow, develop facet arthritis, and then some things can start to happen. You can get leg pain, the foramen can get stenotic, or the spine can start to slip forward, and that can also push on the spine. So that's called a spondylolisthesis as well. So those are kind of some broad terms that kind of explain the pathology of the spine.
Sure. When no tingling, numbness down the leg, like that's very concerning. We get that, we get patients in here a lot of times that have that, and it's so common in here, but it's not necessarily common for the everyday person. It's very concerning when that happens to them.
Right.
And so it's something that we try and provide some reassurance to them and, educate them on what's going on, what that tingling numbness means. Do we have any motor weakness? Can you talk about that just a little bit? Maybe what can cause that first off, and then when that becomes more of an emergency and when they should be concerned and seek further care?
Yeah, great question. So essentially when you start to develop sciatica or radiculopathy, and everybody knows the word sciatica, which is like pain going down your leg, that's typically due to one of those things we talked about. Maybe it's some facet arthritis that's protruding and pushing on a nerve coming out into the leg, or it's a disc that's pushing on that side going down into the leg. So those can present with that pain going down, but sometimes it's not even pain. Sometimes it can be numbness. The reason why some patients have pain versus numbness is really or tingling. It's an inflammatory response. Typically when it's acute and it pops or it's pinching the nerve really hard, the nerve tends to swell. And when it swells, that's called radiculitis. That will present with pain going down the leg. But if it's more on the chronic side and maybe it hasn't pinched, but it's just pushing on it, you'll get just a tingling down the leg.
Okay.
So those are the acute, subacute, chronic, up and down kind of things that we see when it comes to nerves itself.
Sure.
Now, when you already mentioned one of them, when does it become more of an emergency? Well, when we start to have motor weakness, meaning like a foot drop, or a lot of times it's not even the patient that knows it. That's why I love having like a partner or spouse that's in the room, because usually they're like, he's tripping all the time, or I tell her, pick up your legs, you're dragging them. And so those are very, very helpful, because sometimes we can't a lot of times articulate that on examination. We just say, we're getting older, I'm just clumsy.
Yeah.
No, that's not always true. And then one big one that we always think about that should probably take you to the ER is Cauda equina. So that's a scary one, where the disc is so large, it is completely occluded and major spinal canal completely compressed, where now you have loss of bowel and bladder, and you have numbness in your groin and things like that. So those can be very, very scary. But the crazy thing is we see that a lot in women who have pelvic inflammatory disease and some other issues with maybe their bladder, like they've had a previous bladder stimulator or bladder sling. So that's why it's important to have a provider, if these symptoms are happening, to go to emergency and get evaluated. It's not that anybody's writing you off. Maybe we've just kind of ruled that out, and now it's time to see someone else.
Sure. Okay. How often does Cauda equina happen? I've seen it, I don't know, less than a handful of times throughout my career, but it does happen. And so I try and provide some education to patients, just to, not just as a scare tactic, but just as a warning, like, hey, if this does happen, like, you need to go to the ER, get it looked at. But it is rare.
It is rare. But as a spine surgeon, I obviously see it more often, because we get consulted for it all the time as a possibility.
Sure.
But typically, a lot of times when I'm consulted for Cauda equina in the hospital, a lot of times it is not. So I'll tell you that it is rare. However, when we have an acute weakness, loss of bowel and bladder, and it happens, it typically draws us immediately to surgery to solve that problem, because that can cause a permanent neurological problem down the road. And it's not really about the weakness. It becomes like more activities, a daily living problem, like bowel and bladder symptoms that can lead long term.
Sure. Let's talk a little bit about AI and some technology in spine surgery. And, how are we using that?
We use AI all day long, whether it's going to help us in our dictations, whether it helps us on our scheduling. Sometimes we have a whole interface right now at DMOS where we're having a patient call in, and it literally sounds like you're talking to an individual, but it's an AI agent that is able to articulate what you're having and schedule you in the appropriate place, whether it's with a pain management physician, physical therapy, or a spine surgeon. And so those are like the interfacing AI things that we're currently doing. Other things that I'm currently using AI for is actually going to be for surgery itself. And so a lot of that has to do specifically with implants. So a lot of what we've heard about specifically with spinal fusions is that we use these off-the-shelf cages that we use to help open up disc spaces and hold them in place. So these have what we've used for a long time. Now we have, the problem is those can lead to other problems down the road, which we can talk about if you want.
Sure.
But what we've had is with AI, we've been able to run multiple computer algorithms on a particular subset of patient spines and kind of predict, is this cage going to fail or is this going to lead to a problem? And so that allows us to build a cage that has reduced that complication problem. And I have one of those cages here today. So like here, for example, is a cage that was made with AI technology and 3D printed, and you can see it kind of looks wonky, right? And so this cage is made of special material and it's made specifically for a person's spine themselves. And so when we insert these, this is using AI to help develop a cage for a patient's spine.
That's pretty cool. I was going to ask about 3D printing too, so I'm glad you mentioned that.
That's really cool. This is a new company that's come out, and there's going to be multiple coming up, but this is just a very, very small portion of it.
Yeah, that's pretty neat. Now, how, disc replacement versus fusion, can you kind of, I guess, explain what those are and when they would be indicated?
Yeah. So again, kind of going back to surgery in general. So once you've exhausted physical therapy, anti-inflammatories, medications, pain management, which can be an epidural, can be trigger points, things like that, even spinal cord stimulation, all these things. At that point, if you failed all that and your activities are still very, very functionally limited, then you can consider spine surgery. So there are things like laminectomies, which is just essentially an opening or decompression of the spine, or a fusion. So a fusion, like I have a model here, is this. This looks scary, right? So you got screws, rods, cages. Here's a cage right here. And so these are placed around, really, because what we're doing as spine surgeons is reconstructing the spine. So if we have degenerative disc disease, collapse, this is I always talk about it for a patient like a collapsed foundation at your house.
Sure.
I got to restore that. I got to go in there. I got to take out the foundation. I got to put in new, and I got to hold it all together. So that's what spinal fusion is. The problem with spinal fusions, right, is what we know. This works. But what happens is now that force has to go somewhere. And typically what happens is it goes to the SI joints, it goes to the hips, and it goes to the level above or below a fusion. And so that's called adjacent segment disease. So sometimes there's nothing we can do. We have to do a fusion for things like a spondylolisthesis or a slip in someone's back.
Sure.
Or someone has a severe scoliosis that needs to be opened up. And so we can decompress nerves. That's when we're using fusion. There's no room for motion preservation like disc replacement. But sometimes I get patients in my office who have a pretty good looking back overall. They don't have a lot of scoliosis. They have minimal to no slips in their back. And then we can do things like disc replacement. It's for someone that has primarily low back pain. And this is where we've identified that the patient's pain is actually coming from the disc itself. Okay. And so a disc replacement is where we actually go through the front of the belly. So I use a vascular surgeon to get me to the front of the spine, because what I try to avoid as much as possible is taking down someone's back muscles. So when we do surgery, we have to obviously go in through the back, we take down the muscles, but that's trauma. That's taking down good mechanical sparing loads into your back. And so if we can go through the front, we can it's very muscle sparing. We can go in, take out the disc, and then we place this implant in. So this implant is essentially a device that's made of 3 pieces, cobalt chrome, and a piece of plastic that still allows for motion. Okay. But this is not for someone that has scoliosis. This is not someone that has osteoporosis. This is not someone that has a slip in their back. This is someone primarily what's called discogenic back pain. But problem is what I'm currently encountering is actually patients over 60 don't even qualify for disc replacement. Medicare won't pay for it. And so they've classified those patients as unindicated for disc replacement, which is just imagine telling a 60-year-old, I can't do a knee replacement in you because you're too old.
Yeah.
That would be crazy when the majority of our patients over 60 get knee replacements.
Right.
So, yeah.
Yeah. Interesting. So is that something that they can pay out of pocket for then if they
we've they can be expensive surgeries.
Right.
And so I think there are a subset of patients. I haven't encountered that yet. I haven't offered it yet.
Sure.
But again, the reason being is most of the patients, as we get into 65, 70, 75, typically we start to develop slips in our back. We start to develop adult degenerative scoliosis. So that's why they've kind of drifted to, hey, maybe this is not pushing the indication of disc replacement.
Sure.
And so that's why. However, there are plenty of patients who are 60, 65, 75, even 80 who have pretty good looking backs and they just have discogenic back pain. So I think throwing those patients into a bucket kind of, is unfortunate.
Yeah. Put them in a silo and
exactly.
Yeah, I get that. One thing too, I didn't mention earlier, we always tell people whether it's arthritis or maybe a bulging disc or something on the MRI, oftentimes it's just wrinkles in the skin. As we age, they're going to be there.
Exactly.
Doesn't mean it's going to cause problems later on or not, but it is what it is.
Exactly. I mean, I can't tell you how many patients I see in my office who come in, we're talking about their MRI, and a lot of it's me just calming them down. I use that same example. This is like wrinkles on a skin. This isn't your spine is just aging. This is typical, most common levels. And so a lot of times I'm going to send you for an injection, some physical therapy. And I feel like Martians take you guys somewhere. I never see you again because you guys get better.
Sure.
And so it's usually when you're seeing me, I'm the first line of defense to prevent surgery actually. So that's a lot of the time that happens.
Yeah. Talk about endoscopic spine surgery. What's that all about?
Yeah. So endoscopic spine it's been around for a very long time. I know that in America, it may not be, that old, but it's been in places like South Korea have been done for 10, 20, 30 years now.
Okay.
And so endoscopics has just made an emerging market here in America, which is essentially where we're doing, if you've heard of people's knees getting scoped, their shoulders being scoped, we're using that same material. So I'll use a hip scope or a knee scope to scope someone's spine. For the same reason we talked about spinal fusion, because I hate taking down someone's muscle to do any sort of surgery. When we used to do rotator cuff surgery, we used to do them open. We used to open up people's shoulder, tack down the rotator cuff with anchors. But what did we find? People start to develop atrophy of their deltoid because we were taking down that muscle there.
Right.
So then they found a different way to do it through poke holes. And so that's what we're finding with the spine as well. If we can do it minimally invasively through just some poke holes, then we can decompress the spine a lot of the time without having to do a big surgery, which is stripping down all that nice muscle.
What type of surgeries would you do that?
So typically, like we talked about foraminal stenosis, or where the foramen, where the nerve comes out, is kind of pinched. I can go in there with a camera and a small burr and just open up that hole there. Okay. That's one of them. A disc herniation is a great indication for this, where we can go on one side of the spine, make a little pilot hole in, and this is done through an incision that's probably less than 1.5 centimeter, and you're going in and you're just plucking out that disc, or just central stenosis. So someone just has we didn't talk about the ligamentum, but there's a piece of tissue that sits behind the spinal cord that tends to hypertrophy or get bigger with time with arthritis. And so we need to take that out to help decompress the spine. So that's another great indication for endoscopic spine surgery.
Okay, nice. Where's physical therapy fall in all this? I know we talked a little bit about pre-surgery, maybe going to the surgeon isn't the best thing. Yeah. We can look at the medication, physical therapy, injections, things like that. But what about after surgery?
Yeah. So I actually, I'll step back. I love physical therapy prior to surgery. And a lot of it, once again, because a lot of times it can be resolved. Now, a lot of times I have a patient that's come to my office. They have some symptoms that are fairly chronic. And I know they're probably headed down to surgery.
Sure.
So a lot of this is what we call prehab. Like I tell them, look, you're pretty deconditioned. I need you to start doing some things with physical therapy, not because I think it's going to make you better, but because I need a baseline. I need to know where you're at currently because you're so deconditioned. I need some objective measures of what you're currently doing on a daily basis. And then the physical therapist sends this back to me and I actually talk to them on the phone and they're like, oh yeah, this is not good. We're going to need to fix this, this, and that for the patient. So that's one aspect before. And then after, I typically start physical therapy and I have different protocols for that. But typically I'm starting at about 2 weeks. And a lot of physical therapy after spine surgery, regardless, starts with range of motion, edema control, and just kind of pain management sort of things like dry needling, TENS units, massage, things like that. So that's what I utilize initially with physical therapy. And then typically around that 6-week mark, I start some strengthening because now what I tell patients, I'm going to break you down. We got to start from scratch. So I'm taking everything down. I'm going to start you from scratch. We're going to start with range of motion, stretching, and then we're going to build you up and strengthen you all the way up into 3 months.
Yeah.
So that's how I use physical therapy after spine surgery.
I think that prehab, I mean, obviously I'm biased as a physical therapist. I think prehab is a huge component though, too. Not just for spine surgery, but for everything. You know, we always tell people, or I tell people, you know, if your baseline's here and you have surgery, like, you're going to drop.
Right.
But if we can strengthen you up, build your tissue tolerance to here,
right,
you're still going to drop, but now hopefully it's above where you were at the start.
Right.
And so you're just in a much better position.
Right.
Post-surgery, and recovery becomes a lot easier afterwards. So.
Yeah. And you know, to be honest, and this, you know, goes back to, you know, a therapist, that's a special relationship, that it's a very personal relationship. And so when a patient sees me, both of us have to work at this. Like, I got to do a good job in your surgery and you got to be a good patient.
Sure.
And so like, if I'm sending you to therapy, I'm trying to get you bought in on your protocol. If I have a patient who's very reluctant on doing therapy and very reluctant to any non-operative care, it's probably not going to be a good patient that's going to do well with surgery. And that's because this is a two-way street, right? I'm trying to make you better, but it's not going to just be me. Right. So I have patients where I do these very large spinal fusions and scoliosis corrections, and we're at a year out and they're happy. They're hugging me. They're, thank you for everything you've done. I couldn't have done this without you. And I stopped them right there. I was like, I was a very small portion. I know that we did a big surgery on you, but you have your pain doctor, your therapist, you have you and everything that you put into this. There's so much that has gone behind than just me. I know that there's an x-ray that's taken and it looks nice and all this stuff, but there's so much has gone up to this point. And a lot of it, I give the credit back to the patient because they've done such a great job sticking with the regimen. Yeah,
absolutely. I mean, obviously we don't do the surgery, but from the rehab standpoint, you develop a big relationship with these patients, and you know, a lot of times they're happy at the end. They're thanking you, and you know, they're really appreciative. But it's at the same time, it's like, well, you did the work. I didn't. Like, I'm just sitting here telling you what to do. But you got to do it. So
exactly. And therapists are honestly great advocates because a lot of times as a spine surgeon, I become busy. You know, like you're coming in for your post-operative visit. I see you for just a snapshot in time where we're maybe talking about what you're currently doing pain-wise, what your work-life balance is kind of looking like, and then you go right out the door. And then sometimes I get a message from a therapist that says, hey, you know, John is not doing well. I saw him 2 weeks ago. He was doing pretty good and he's regressed. Something's happened. Sure. And do you mind getting him in here so that you can kind of evaluate? And that kind of my red light starts going off. So then the patient comes in and they're kind of, you know, maybe a little pissed off and they're like, hey, you know, I don't know what I'm doing here, you know, and I'm like, well, you know, your therapist thought that something's wrong. Let me evaluate you. And sure enough, we find some weakness or something. Yeah. And then we get, you know, then I'm ordering an MRI right away after a surgery and then starting to see maybe we have another disc herniation or re-herniation or something's happened after surgery. And those are very important to me after spine because you guys do such a great job being so objective in your measurements. And so when there's a regression, that's something that needs to be taken seriously.
Sure. I want to talk about a couple things that I'll give air quotes controversial. I guess controversial more in the sense that like maybe research doesn't show efficacy. You mentioned dry needling. That's something we do a ton here, but when you look at the research, it's not great.
Yeah.
So I just want to hear your thoughts on it. You know, some people are very against it. It's like, well, you're just stabbing someone and it's a placebo. It's like, well, if the placebo is working, then
right. Yeah. I mean, there's so many placebos in medicine.
Right.
And what I try to explain to patients when it comes to research itself, right, this is in a vacuum. you're taking the perfect patient, the perfect ideal surgery, everything,
Yeah.
and then the perfect diet, the perfect health, everything coming into place. So when I talk to a patient about certain therapies like dry needling, I tell them, look, in my experience, this has been very beneficial, even for myself, because I've done dry needling. And trust me, I won't do anything that hurts because it can hurt sometimes.
Right.
And I'm not going to do it and keep doing it just because
Yep.
it doesn't work.
Yep.
And so there are certain things in my practice that I find that, hey, dry needling specifically helps with this, specifically with spinal fusions after, 6 weeks of deconditioning, that muscle's atrophied and scarring down.
Right.
We got to break through that scar tissue. We need some muscle activation because typically the patients, they're coming in, they're bent over because their back is all spasmed.
Yeah.
And I think dry needling really helps for that. And it's very similar to me to acupuncture. And then there's different aspects of like acupuncture,
Right.
like superficial and deep acupuncture. Now that deeper acupuncture does take a specialist to do. You can't just have anybody do it. But I just don't think we're there yet. I don't think we're there yet in the sense of research to really dial in the patients that are going to do well with it and whether it's placebo or not.
Yeah.
So I think just like a lot of things that we have in medicine, like GLP-1s, like weight loss medications that now we're finding that now people are saying that some of it causes Alzheimer's and things like that.
Yeah.
Until we have longer data and better patient sets, I think it's very hard to just say that's a placebo.
Sure.
So I think if it helps for some of my patients, then perfect. I'll use it.
Yeah. So give you some background on me a little bit. I was in the Navy before this, did a residency, and part of that they sent us down to Fort Sam Houston, and we did a lot of different things, but one of them was we got certified in dry needling. And the faculty for the residency were all the Army Baylor physical therapy faculty.
Right.
And so a big part of what we did, we went body part by body part. We'd go to the classroom and they'd say, for back pain, here's all the research we have for back pain and dry needling.
Right.
And then we'd go to another lab where we had prosected cadavers and we'd practice. And then we'd go to another lab, we'd practice on each other. And so after like 9 days going through the whole body, getting certified in this, I was sitting there like, why are we doing this? Like, none of the research really supports this. And so I was like, there must be something to it. They wouldn't have us do it if there wasn't. But also, like, the research doesn't support it. I'm like, I don't get it. So my whole plan is I was like, I'm going to go back. I was in Washington State at the time. I was like, I'm going to go back to the hospital there. I'm going to get certified. I'll put it on my fit rep for the year. I'll look good. I'm never going to use this again.
No, I think it's just like a lot of things in medical practices, right? It's just the modalities that you offer.
Yeah.
So again, this gets patients bought in on over their protocol. So if I can get a patient that's going to be consistent with something, I think overall they're going to do better. Like if you wake up if you wake up every morning and you make your bed for 90 seconds and you drink a glass of water, your whole day is going to be better. Right.
Yeah, right.
And this is very similar. So I tell patients, you're going to do this. And it's kind of like Pavlov's, theory. Like if I can do this to you and you can do this every time, maybe you end this with this. This is kind of like your treat at the end of it.
Right.
And so I think it just builds consistency for some patients.
Sure.
And some patients it doesn't work for. So I think no matter what it is, I think consistency is key.
Sure.
Whatever you're doing, whether
absolutely.
it's physical therapy, medication, and just the consistency of itself. So if you consistently get dry needling and you believe in dry needling, it probably is going to work for you.
Yeah. A lot of people love it. And that's what I found too, as I was getting credentialed for it. It's like, there's things that just general physical therapy that should be helping was not helping.
Yeah.
And all of a sudden I stick this needle in there and they come back and they're like, I don't have any pain. I'm like, what are you talking about?
Yeah, exactly. I mean, it's just like TENS units, right? Like TENS units, like, some people just love that sensation of that muscle contraction and some people cannot stand it, So again, this is a subjective thing too. So some people, I just feel like they cannot tolerate dry needling. They just do not, they say it makes it worse.
Sure.
And so and then you just find that subset and it's a modality you offer. That's great.
Yeah, absolutely. Now, one other thing I wanted to ask you about, physical therapy has been using it forever. And now it's kind of got rebranded. I see it mostly with chiropractors, traction. So lumbar traction or cervical traction.
Yeah.
You'll hear it as decompression. They've got these decompression tables and they've got these like big elaborate things. And it's like, it's marketing.
Yeah.
But it's really hard to tell people that when they come in, they're like, I'm going to go do this. And you're spending $2,000. It's like, well, physical therapy will pay for that. Like I don't have it here, but some clinics do.
Yeah.
You can bill for it.
Yeah.
But that's another thing where at least for me, I found, research doesn't really support it.
Right.
But I found like for the right person,
Mm-hmm.
it makes all the difference. Like I've had people get off those tables and ask like, where do I get this? Like I want to buy one for home,
Yeah.
This feels great.
Yeah.
And so talk about that a little bit. Like what's your thoughts on it? And
I mean, I think, personally, I think it does work, but again, it can be expensive depending on where you go. So I tell patients, because some of them they love chiropractic, and I utilize my chiropractic colleagues a lot.
yeah,
But I tell them, like, look, from my standpoint, just like stem cells and things like that, it's very hard for me to sleep at night knowing that I paid a lot of money for something and tell myself it didn't work. I got to tell you, it's got to work because I just paid a lot of money for it. So
right.
I think there's a placebo effect there,
Sure.
and a little bit of it. And then there's the aspect of just the actual decompression itself. Some of these patients, when you have degenerative disc disease, that ligamentaxis or that pulling does actually help.
Yeah.
And so the problem is we live in a world of gravity. Yes. And so as we stand up and we start moving again, it's all going to go back down.
Yeah.
So I tell patients, I'm like, look, if you want easy decompression, get an inversion table or just hook yourself upside down and then just stretch or hang from a bar and just bend your knees and just stretch yourself. Those are really cheap things that you can find at a playground that you can decompress yourself. The problem is we're not bats and we can't just live upside down
can't
forever.
Sit there all day.
And so, but I do think there is something behind it. I just think I personally wouldn't throw thousands of dollars at it for the therapy.
Yeah. Yeah. Like I said, I think it's become more of a marketing thing.
Correct.
And you see some of these devices that are just like, they're huge. And they're elaborate. And like the ones we had, like when I was in the Navy, they were tiny little things hooked up to the end of the table and you put them on the harness, but it's the same thing. So I don't know. It's kind of interesting.
Right. Yeah, no, absolutely.
So, and I don't want to throw shade at chiropractors. We've got chiropractors we work very closely with too.
Yeah.
I think that's a question people always ask me is like, you must hate you must hate chiropractors because you're a physical therapist. And it's like, no, like there's good ones, there's bad ones, but hey, there's good physical therapists and there's really bad ones out there too. So it's not that I hate them. It's just,
right. No, I think, again, just like a therapist, just like a chiropractor, just like a physician, I think there's value of literally placing a hand on a patient. I think that makes a big deal for patients because some patients just feel like they just, once you touch them, they just feel better. I don't know what it is. Yeah. And so I think chiropractics really, they are very in tune with that aspect of medicine of just touching a patient, feeling where the soft tissue rigidity is.
Sure.
But then, there's the business side of it. Right. And so, whether or not that helps, I don't know. If it works for a patient, I'll advocate for it. I tell them, does it help you? And if they're like, yeah, I'm like, go do it. If that's your prerogative, go do it.
Yeah. It's a good place to start before getting your spine operated.
Exactly. Right. Because this is not the best option in the world. Right.
Yeah. Well, and I'll tell people that, I mean, it's 2026, but like, that's a big surgery on your back. Like there's places we can start.
Exactly.
Beforehand, before we get into that.
Yeah. And then the scary part is when I have patients honestly come in and they're kind of defeated and they're the last place I tell patients you want to be is in a place of pain making decisions because people get desperate and they want to get out of pain. And I tell them like, let's get you into therapy. Let's start some pain management because once you're thinking clearly, you can make some informed decisions before you just jump into a surgery that may or may not help you. And so, I like to think I would do a good job. But just like we talked about, there's a psychological component of it. Yeah. Some patients, I come in, they got bad disc disease. They got all these things going on. I start to ask them about their life. I'm like, what else? What do you do for a living? Well, I just got laid off. Okay. Well, have you found a job? No, I haven't. And then they do therapy, do some injections, find out they come back, they got a job and they're feeling better. Yeah. And so it's like, there's a psychosocial component to back pain and stress and things like that for sure.
Yeah. Yep. Yeah. We like to talk to people about the pillars of health. So movement, obviously that's our bread and butter, but nutrition, sleep, stress management, like there's all these things play into it. And it's kind of a vicious circle. If you don't take care of one, it's going to affect the other.
Right. Exactly.
So, yeah. Well, is there anything we haven't talked about that you want to talk about or you want people to know?
I mean, I think what you hit on there last, I think is key. I think just overall taking care of your body, and it just comes back to consistency with diet, motion, stress management. If you can do a lot of these things, your spine, whether it's the worst spine in the world or the best spine in the world, it's going to find a balance. And if you're having continued problems, see your physical therapist, come see us at DMOS. We will take care of you. We'll come out with a treatment protocol for you. But I think a lot of the times people just need a diagnosis to move on with their life. So get diagnosed and then just move on, find a treatment protocol that works for you. And a lot of times that doesn't involve surgery. That doesn't mean it's the end of the road for you and there's no one that can help you. That means that it's probably not the best option for you. And there's another modality that's probably been proven that's going to work for you better than surgery. But if you're offered surgery, I think the last thing or a lot of the times what I hear, a patient will, mom and dad had spine surgery. And they did not do well. Yeah. And I'm really scared to go into the knife, doc. And I tell them, that's because you're normal. If you're scared to go into the knife, that means this means a lot to you.
Right.
But spine surgery today has completely changed to what it was 20 years ago. And it's become more minimally invasive. We've learned to do less is more type surgery. And so a lot of times if we're offering surgery, it's because we do believe it's going to help you.
Sure.
But the caveat is if you're going to implement all the other things around spine surgery to help you long term.
Yeah. One thing I guess we didn't talk about too before we wrap up here, what necessarily causes these different things? I know that's a broad because there's a lot of different things, but what causes these problems and how do we prevent it?
Yeah.
Or can we?
Yeah. So some of it is truly just genetic. I mean, a lot of times when I get patients in the clinic and I'll get a 28-year-old, just a terrible looking back. And then I'll start asking about mom and dad, and mom and dad had a terrible looking back. And a lot of it has to do with the soft tissue, the collagen. There are genetic components to degenerative disc disease.
Okay.
And then it goes back to all the other things, diet, inflammation. And then sometimes I get, Army, Navy guys who, I get some parachuters that are flying out of pain. They have bad disc disease because they are spending all day just pounding on their back. This is a mechanical problem. And so that can advance degenerative disc disease. So what can you do to prevent it are going to be core activation. I personally use the McKenzie protocol. I'm doing a lot of dead bugs all the time to help with my low back to keep my core strong. Working out, keeping your diet right, keeping your weight managed, all those things really do help. But then at the end of the day, back pain is so prevalent. Spine in general, surgery is so prevalent because it is a problem. And our backs are a mechanical device, just like the cars that are sitting outside here. They're brand new at one point. You drive them long enough, they are going to start having problems. It's not because there's something wrong with the manufacturer, but it's just wear and tear, right? And some of that we just can't prevent.
Yeah. Are you familiar with Stuart McGill?
No.
He's like a researcher, spine researcher out of Canada, but he's got some different, like the big three exercises, those different things. He's a big advocate of. I guess where I was going with that is, let's talk like weightlifting.
Yeah.
Squats, deadlifts. One of the big things he talks about is loading the spine under flexion. Mm-hmm. So that's a no-go for him.
Yeah.
Some people will say, well, we can progressively load the spine in flex positions. Yeah. And it's not a problem.
Right.
So I guess what's your take on all that?
I think this goes back to my concept of pelvic morphologies. Mm-hmm. So when we look at the lordosis, which when you hear that word, that means the curve in someone's back. That's normal. You should have a certain amount of curve in your back. Everybody's different though. There are typically 4 or 5 different types of morphologies of that curve. And so I think some patients who have a lot of lordosis are probably not going to do that well with that load-bearing flexion because there's such a high shear moment on those discs that tend to advanced degenerative disc disease very, very quickly. And then there's some that have very little who can those are the guys that we see at probably the weightlifting competitions that these guys can freaking lift a bunch of weight because it's just straight down load on those discs. So I think there's a pelvic morphology, but like me personally, I have a slip in my back and I don't know what it is. I can squat and it feels better to squat, to load weight on my back. Yeah. If I just do the bar, my back hurts. But if I load weight on it and start doing squats, it starts to feel better. And so I think there's like a viscoelastic component that's happening with fluid in the disc. Yeah. And so there are some benefits to loading the spine, as we know with things like osteoporosis, helps with building bone and things like that. But then I think also that there's some mechanics that are happening with the muscles around the spine that start to get activated and it helps with that back pain.
Sure. Yeah. What's your thoughts on deadlifts?
I hate deadlifts. I do them. I do
personally or from professionally?
Yeah. Professionally. I think that, and it has nothing to do with the moment itself. I think it's just it is one of those activities that is done improperly so many times.
Yeah.
And it leads to so many injuries because it's done improperly. And typically what happens is it's not going to be, well, yeah, it'll happen when you're trying to PR on a deadlift, right? But it typically happens at a point of fatigue. Where I'm seeing more patients with deadlifting injuries are because they were on their 10th rep and they just lost form, and then they bent over wrong, and then they felt it in their back.
Yeah.
And that it goes to fatigue, because you can't do that motion too many times before your muscles just fatigue and give out.
Yeah.
And that's a dangerous place to be in. I mean, sometimes that can be debilitating. I was at Lifetime the other day, and there was a guy who was deadlifting and he fell to the floor because he herniated a disc in his back, and he was in a debilitating pain, and he had foot drop after.
Ooh.
And so those very dangerous.
Yeah.
I do them personally, but I will do them like I have to focus when I'm doing them.
Sure.
And a lot of the times I'm listening to music because I have to lock in because my injury occurred after a deadlift.
Okay.
And so that's my
yeah. Do you think things more like a hex bar deadlift?
Mm-hmm. Yeah.
Where you don't have that weight out in front of you, it's more centered.
Yep.
What's your thought on that?
Yes. So, and to go into that point, there are just so many better exercises to do if you're trying to activate the glutes and the hamstrings comparatively to a deadlift.
Sure.
Even a sumo deadlift is probably better than just a standard deadlift.
Yeah.
But there's so many types of other exercises that all you're going to be doing is bringing the center of gravity closer to you with these types of like the X bar. With the problem with the deadlift, again, it's a pendulum. The more you're pulling that weight away from you and you're bringing them back, you can lead to a bicep injury where you pull tear your bicep off your radial head, or you can get a back injury. And it just has to do with that weight and that center of gravity. They have I've been using this new machine that has this belt that you put in, and it has the chain down on the floor. And
we've gotten right.
Exactly. So and so that's a great activity where you can keep your center of gravity, and you'll have lower incidence of injuries, and you'll really get that activation that you're looking for.
And a lot of people that have pain with a standard deadlift or squat, even you've got that belt where it's providing a little bit of traction. And then they can still load their legs. And so
I mean, simple box step ups. I mean, I hate them. I hate them. But if you do them slow enough and you do them progressively weight loaded, you're protecting your spine. You will activate the muscles you want to activate and probably make you stronger than a deadlift. To be honest with you.
Yeah. What about cyclists where they're kind of in that flex position, rounded back? I think that's more of a hip issue, or?
Yeah. No, you see spine injuries with cyclists for sure, but biking itself, it depends on the type of biking that you're doing. Typically, if you're doing a track bike, it's very flat, stable roads. So that's not typically the issue comparatively to off-road biking type of issues. But that kind of flex posture, I think that has to go into, they just trained like that. So their spines become very, very adaptive to that position over time.
Sure.
And I mean, if you look at these guys, you'll see them, they look like they have turtle shells on their back because their backs are so freaking strong. Because when they're taking that bike and they're going uphill, they're literally almost doing like a rows as they're pulling that bike coming up. And so they're activating those lats a lot. So that I don't think will be so much a problem. What we typically see is some degenerative disc disease from that kind of that pounding moment on the bike seat.
Sure. Awesome. Well, if people want to know more about you or they want to get some more information, how can they do so?
Yeah. Come see us. We're just opening up a clinic in Norwalk. So at DMOS, we have appointments available immediately. I'm also located in West Des Moines. And I have two other partners, Dr. Zach Reese and Dr. James Hall, great spine surgeons and partners that we're willing to talk to you and sit down with you and formulate a plan. Come to Kaizen Health and Wellness, get your physical therapy done.
Appreciate the shout out.
So that we can get you taken care of. You don't have to live with back pain. You really don't. There are treatments that are ready for you and ready to get you back to your normal